Let's go over the 3-question warm-up for Neuro 19. First question, which gram-positive organism matches each of the following statements? So an infant with poor muscle tone, that's going to be Clostridium botulinum, and botulinum toxin. Diarrhea after using antibiotics, think about Clostridium difficile. Respiratory distress in a postal worker, what we're going for here is Bacillus anthracis. Right after 9/11, there was this huge concern that there was going to be inhalation anthrax spread through the postal service as an agent of biological warfare. Then otitis media in children is most commonly strep pneumo if it's bacterial at all. Now, lots of time, otitis media is a viral infection. And then cellulitis is most commonly going to be Staph aureus and strep pyogenes, or group A strep. Next, what's the classic presenting symptom in a patient with Lyme disease? So classic presenting symptom is erythema chronica migrans, which is an expanding bullseye rash with central clearing. And the last one, what's the function of macrophages in the spleen? So macrophages in the spleen remove encapsulated bacteria, and they remove dysfunctional cells like dysfunctional red cells. Now let's get started with the lecture.
Hello everyone, and welcome to our Step 1 video on the upper extremity nerves. Guys, you've been studying forever by now, and by this time, you're now in one of about 3 groups. The first group consists of students, though fatigued, are focused and are now kicking it into the next gear to keep the learning going. Group 2 consists of students who are on the brink of a freakout. Their brain is at capacity and they're not feeling too good. Don't say high yield or they'll pop. Then the third group are the ones that have already given up and are now watching these videos as a part of a drinking game. Anytime I say moving on, they take a drink. I'm told I say that a bit. So, all right, moving on. So today we're going to cover the brachial plexus and the upper extremity nerves. And before we talk about the brachial plexus, we need to talk about the anatomy of the neck because it's actually pretty important to know for step 1. Now, it's always hard to teach anatomy because most of the time we have to say, hey, look at that. You should probably remember that. So you may need to break out the old anatomy book again, brush away the cobwebs. So our strategy is not to waste a bunch of your time showing you every anatomy picture that we can find and tell you, well, that's important, remember that one. Instead, we're going to try to hit the highest yield anatomy and then cover the pathology associated with that anatomy. So let's move on to the neck. First of all, one way to organize the neck is to separate into 2 distinct and different triangle regions, which are separated by the sternocleidomastoid muscle. So the first thing you need to do is locate that sternocleidomastoid muscle. So that's separating the posterior triangle from the anterior triangle. Well, what forms the posterior triangle is the sternocleidomastoid, the trapezius muscle, and the clavicle. Sternocleidomastoid, trapezius, and clavicle. So what is in the posterior triangle? Well, you have the brachial plexus. Near the clavicle, specifically at the mid-clavicle, you have the subclavian vein. Also in the posterior triangle, you have the external jugular vein. And then a muscle that presents in the posterior triangle overlaying the posterior triangle is the inferior portion of the omohyoid. So that's also on the posterior triangle. So let's go on to the other side of the sternocleidomastoid and talk about the anterior triangle of the neck. The anterior triangle is formed by the midline of the neck, or the trachea, and the mandible on the superior aspect, and then on the lateral aspect, again, that sternocleidomastoid. So what do you have in this region? Well, up in the superior aspect, you have the posterior digastric muscle and the anterior digastric muscle. In the midline of the neck, you have your sternothyroid muscle. Lateral to that, you have the sternohyoid muscle. And then lateral to that, the superior omohyoid muscle. And then as that muscle goes down inferiorly and goes into the posterior triangle, it then becomes the inferior omohyoid that we talked about before. All right, so we just saw the brachial plexus in the posterior triangle. The brachial plexus is a network of nerve fibers that originate from the spine and ultimately result in the named nerves that we know that supply sensation and muscle innervation to the upper extremity. So now let's label the brachial plexus. This is a 4-star topic. Most of you are going to get a question on this. This is also going to be in the study guide as well. So the brachial plexus comes from C5, C6, C7, C8, and T1 nerve roots. And then the roots become your trunks, which then become your divisions, and then your chords. And then finally, the terminal branches. And so there's a few different mnemonics that you can use to remind you of this. The one that we've used around here is Randy Travis drinks Coors beer, and that's going to again go for roots, trunks, divisions, chords, and then branches. But whatever works for you, but let's go ahead and take a look at these. Okay, so let's label this brachial plexus. First one here, we have letter A. Letter A, that's going to be the long thoracic nerve. The long thoracic nerve innervates the serratus anterior muscle. Now, one good way to remember the serratus anterior is that innervation here for that long thoracic nerve is the word SALT, S-A-L-T. So S-A for serratus anterior, L-T for long thoracic. Letter B is the suprascapular nerve, which is coming off of the superior trunk, and the suprascapular nerve innervates the infraspinatus and supraspinatus. Letter C, coming off of the lateral cord, is the lateral pectoral nerve, which innervates the pectoralis major. Letter D is the upper subscapular nerve, which innervates the subscapularis. Letter E is the thoracodorsal nerve, which innervates the latissimus dorsi. So these are all coming off of the posterior cord. Letter F is the lower subscapular nerve, which innervates the teres major. And now moving on to the terminal branches. G is your musculocutaneous nerve. It innervates your biceps, coracobrachialis, and brachialis, the main flexors of your arm. Letter H is going to be your axillary nerve, which innervates your deltoid and teres minor. Letter I is your radial nerve, which innervates your extensors and your triceps. If you injure your radial nerve, then you're going to get a wrist drop. Letter J is your median nerve, which innervates your pronators and your thenar muscles of the hand. And then letter K is your ulnar nerve, the little baby nerve of the hand. It innervates your interosseous muscles and your hypothenar muscle, so your little pinky muscle. All right, so I bet you got all of those right. Well, maybe a few of you don't have it quite memorized yet, so we better go through this again in a Lewis Notes. All right, everyone, welcome to a Lewis Notes. We just got done labeling the brachial plexus, but we're going to do this again a different way. I want you to draw it out yourself, because I think if you draw it out yourself, you're going to learn it even better. So we're going to go through this together. We're going to go slowly, because the more times we go through this, you're going to get it. And then we're going to label it again in an end-of-session quiz at the end. So let's go through this together. I want you to set up your piece of paper, put at the top roots, trunks, divisions, chords, branches. Randy Travis drinks cold or Coors beer. Sometimes the branches are referred to as the terminal branches, but we're just going to use branches here. And then on the left side, we have C5, C6, C7, C8, and T1. All right, so starting with the roots, I want you to make a triangle right here, and then on C7, it's just a straight line, and then on C8, T1, we do another little triangle-looking thing here. Now, the hardest thing about the roots is that there's this weird nerve that's going to come off right here. It's going to get multiple innervations here. And what's going to be that one that goes right there? Do you guys remember that one? Remember, that's going to be your long thoracic nerve. So you're going to take long thoracic and you're going to put that one right there. So let's go back to our drawing now. So if we go back to our drawing, we're going to go to our trunks area. So if we go to our trunks, we go across there, we go across there, we go across there. There's not a whole lot to remember on the trunks. There is one on this top one right here. Do you guys remember which one that was? That was the suprascapular. So I want you to write in suprascapular right up here. Moving along, divisions. Thank goodness we don't have to know anything about divisions. You just keep on rolling right through there until we get to our chords. Now our chords is a whole different scenario. We got a lot of chords that we have to remember here. So let's go through here like this. Let's go like here like this. So in our chords at the top here, we've got one up there. Which one is that going to be? That's going to be our lateral pectoral. So let's grab our lateral pectoral and let's put that right up there. Now our middle one is going to be our most difficult chord section. We've got three over here. So you're going to have one there, you're going to have one here, you're going to have one here. What are going to be the ones that we connect here? So remember, the first one is the upper subscapular. So the upper subscapular is going to go over here. The next one is the thoracodorsal. So the thoracodorsal is going to be the middle one right there. And then the third one is going to be the lower subscapular. So the lower subscapular is going to go down right there. We don't have a whole lot of room there, but we'll just kind of sneak it in. On the bottom section, there's nothing to remember. Now, the next section that we're going to do is our branches. So the branches get a little complicated as well. You're going to have a little break right there, and then you're going to have it go all the way down, and then you're also going to have sort of this V connection right here, and you're going to get another nerve right there. So let's put all these things in. So in this little V right here, we have our axillary nerve. On the bottom part of that, we have our radial nerve that's going to go right there. On our top, at the very end here in our terminal branch, we have the musculocutaneous nerve. In the middle here, it's easy to remember because it's the median nerve that's going to go right there. And then our bottom, the ultimate nerve, the ulnar nerve, is going to be the one that goes in right there. So if you can write this out yourself maybe a couple of times, I think it will stick in your brain. And then we'll actually do this again in our end of session quiz. And now for our second review of the material. We're going to add in some detail to the anatomy, and we're going to start to learn the muscles and their functions. Again, don't panic if you don't get it all now. We'll cover this again in the next video, and we'll cover the pathology there as well. So the first one here is the long thoracic. So this is going to innervate the serratus anterior. Remember the mnemonic SALT. Now the serratus anterior is a muscle that originates on ribs 1 through 8, and then inserts at the medial border of the scapula. So the muscle's just below the armpits. It holds the scapula onto the thorax. Next, we have the suprascapular, and this is going to innervate the infraspinatus and the supraspinatus. Now, these are parts of the rotator cuff. Now, the infraspinatus externally rotates the humerus and stabilizes the shoulder joint. The supraspinatus is going to act to abduct the arm. Next, we have the lateral pectoral nerve. So this is going to innervate the pectoralis major. So it makes up the bulk of the chest muscles. Now it has several actions, including flexion, adduction, and medial rotation of the humerus, and it acts to keep the arm attached to the trunk. Next, we have the upper subscapular, innervating the subscapularis. So this is a triangle-shaped muscle that fills the subscapular fossa. It inserts into the lesser tubercle of the humerus and the front of the capsule of the shoulder joint. The subscapularis acts to internally rotate the arm. Next, we have the thoracodorsal. It's going to innervate the latissimus dorsi. Now, the lats are responsible for extension, adduction, transverse extension, and flexion from an extended position, and then internal rotation of the shoulder joint. So that's a mouthful. So how are you going to remember all that? Sometimes look at the weightlifters and see what exercises they do to work out a certain muscle. That gives me a better idea of what that muscle does. So to work out the latissimus dorsi, you can do pull-ups, or even better, lean over and pull up a bar or a dumbbell. Next, we have the lower subscapular nerve. This is going to innervate the teres major. So it originates on the dorsal surface of the inferior angle of the scapula and then inserts on the medial lip of the intertubercle sulcus of the humerus. Now this muscle medially rotates and adducts the arm. Next, we have the musculocutaneous. That's going to innervate the biceps, the coracobrachialis, and the brachialis. So these are the major flexors of the arm and forearm. Next, we have axillary nerve. That's going to take care of our deltoid and teres minor. The deltoid acts to abduct the arm, especially along the frontal plane. The teres minor acts to laterally rotate the humerus. Next, we have the radial nerve. So that's going to be your extensors and your triceps. So the triceps and the extensors act to extend the forearm, and we'll cover this in even greater detail in the next video. Next, we have the median nerve, so the pronators and the thin arm muscles of the hand here. So these act to pronate the forearm. It has other functions in the hand, and we'll cover again that in the pathology in the next video. Ulnar nerve, so flexor carpi ulnaris, interosseous muscles, and your hypothenor muscle. So in the forearm, the ulnar nerve acts to flex and adduct the hand. And the hand, again, we'll cover in more detail when we go through the pathology. Okay, so that's another review of the upper extremity nerves and the muscles, and we've also labeled the brachial plexus. All right, so make sure that you can label that brachial plexus and know what muscles are innervated by those nerves of the brachial plexus. And while we're talking again about the brachial plexus, I want to talk about one specific lesion of the brachial plexus, which is an injury to the superior trunk or an injury to the C5 and C6 nerve roots. And that's going to give rise, again, to that superior trunk. Now, so if you injure that area, that causes Herb Duchenne palsy, also referred to as waiter's tip syndrome. And so what causes this? Well, you can injure this area by trauma. The shoulder or neck can be traumatized, leading to kind of a violent stretch of the nerves of the superior trunk. Now, the most common scenario is seen with dystocia during newborn delivery. The infant's head and neck are kind of pulled towards the side at the same time as the shoulders pass through the birth canal. Now, it can occur with excessive pulling on those shoulders during a cephalic delivery as well. So you can also see Herb Duchenne palsy in newborns with clavicle fractures, even if it's not due to a dystocia. Dystocia occurs more often, again, in large for gestation babies, so be on the lookout for that on your test. So how does this present? Well, the paralysis can be partial or complete depending on the damage. Sometimes we see just kind of bruising or stretching of the nerves, and sometimes we see complete tearing of the nerves. Now, the most commonly affected nerves are going to be the nerve branches for the suprascapular nerve, the musculocutaneous nerve, and the axillary nerve. So with those nerves being affected, what are you going to see here? Well, there's going to be loss of sensation in parts of the arm and atrophy of the deltoid, the biceps, and the brachialis muscles. The limb is going to hang down by the side, so you have paralysis of your abductors. It's also going to be medially rotated, so you have paralysis of the lateral rotators, and the forearm is pronated, so you have loss of the biceps. So it kind of looks like a waiter asking for a tip kind of behind the back in kind of like a little subtle way. Now, usually infants will regain full function if there's only bruising or stretching of those nerves. Now, if there's complete tearing, unfortunately, then sometimes the symptoms are permanent. Now, another portion of the brachial plexus that can be injured is the inferior trunk, so that's C8 and T1. So what happens if you injure the inferior trunk? Well, you get Klumpke's palsy, which is much less common. Now, this injury can again occur during a difficult delivery. So this can result when there is traction on an abducted arm. So if the infant is pulled from the birth canal by an extended arm kind of above the head, that's when this can happen. It can also happen to an older person who, for example, tries to catch him or herself by a branch while falling from a tree. Now, when an injury to C8 and T1 occurs, there is subsequent paralysis of the intrinsic muscles of the hand. So you've got to think about the interossei, the thenar, and the hypothenar muscles. There's also potential paralysis of the flexors of the wrist and the fingers. Now, the classic, very severe presentation is going to be a supination of the forearm with wrist and fingers flexed. But you can also see wrist and finger weakness leading to kind of a virtually flail hand and wrist. Now, there's also going to be sensory deficits on the medial side of the arm, forearm, and hand. All right, that's going to bring us to the end of the video part. It's time for that end of session quiz. Try to answer those questions on your own, and then we'll go through the answers together. All right, first question. We're going to do another big labeling here. This is a big part of this lecture here. So let's go through this again. Letter A, that's going to be the long thoracic nerve. Letter B is the suprascapular nerve. Letter C, coming off of the lateral cord, is the lateral pectoral nerve. Letter D is the upper subscapular nerve. Letter E is your thoracodorsal nerve. Letter F is the lower subscapular nerve. Letter G is your musculocutaneous nerve. H is the axillary nerve. I is the radial nerve. J is in the middle, it's your median nerve. And then letter K is going to be the ulnar nerve. All right, next question. What are the symptoms of a lesion to the C5 and C6 nerve roots? You got to memorize the C5 and the C6 part of this. So this is going to be our regular old Herb Duchenne palsy, which would show symptoms of paralysis of the upper extremity, including paralysis of the lateral rotators, biceps, and abductors. Remember that waiter's tip. So that presentation again is the arm hanging limp at the side, medial rotation, forearm pronated, and again, buzzword waiter's tip. All right, next question. What are the symptoms of a lesion to the inferior trunk of the brachial plexus? Remember, that's our Klumpke's palsy. So those symptoms would be things like sensory deficits of the forearm and hand on the medial side, upper arm as well. You're also going to see atrophy of the hand muscles, so the thenar, hypothenar, and interosseous muscles. All right, so then we have one rapid fire fact. You should know this one by now. Newborn with arm paralysis following a difficult delivery. First, think of Herb Duchenne palsy. You might have Klumpke on there, but Herb Duchenne is going to be far more common. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.